Keynote address, we have Dr. Molani. He is going to give his keynote address. Sir, all over yours.
Thanks very much.
He is from Pune. He is a great ophthalmologist, a cataract surgeon. Just now found out he is done from Rohtak, his MBBS. And so welcome, Dr. Ashok Kumar.
Thanks very much. Good morning, everyone. Nice to see you all in person at this prestigious AIOC conference after a gap of 2 years. I thank the Chairman Scientific Committee for inviting me and to give a talk in Dr. Amit Porwal's instruction course. As you see, the white cataract, it poses 3 problems. Preoperatively, it is difficult to do a good biometry. There is poor fundal glow. And lastly, there is a raised intralenticular pressure. These cataracts are actually waiting to explode like a volcano. Since biometry cannot be done preoperatively, so immersion biometry is a must, or do biometry of the fellow eye. Do B-scan to rule out any posterior segment pathology. Also rule out any history of trauma or lazy eye. The most important part is counseling for the prognosis and explain to the patient the risk of complications. Preoperatively evaluate the type of cataract and look for any subluxation, phacodonesis, RAPD or retinal detachment on B-scan. Because of absence of red reflex, staining of the capsule with trypan blue is a must to improve the visibility. This also makes the capsule less elastic. Raised intralenticular pressure may cause dreaded Argentina flag sign. Pressurize the AC with high molecular viscoelastic to flatten the bulging anterior capsule and then perform the rexes. Pressure in the anterior chamber must be higher than the intralenticular pressure. To prevent the peripheral extension of a capsular rexes, you can either do a spiral rexes or you can do femtolaser or do puncho rexes or recently described by Dr. Rajendra Prasad swing needle microcapsulotomy. However, with femtolaser, the cataract absorbs some of the laser, so you may have incomplete capsular rexes. If you do not, here is a video which showing a white mature intumescent cataract where the AC was not inflated and the anterior capsule was not flattened, so you see the Argentina flag sign. I'll show in my video how we manage. First of all, we stain the capsule with trypan blue, then inflate the anterior chamber with viscoelastic, flatten the anterior chamber, then make a puncture with the cystitome 27 or 26 number needle. Then you will see a lot of milky fluid coming out. Try and suck from under the capsule so that you release the intralenticular pressure. Also press the nucleus posteriorly so you get the fluid behind the lens also, nucleus. Then you can continue the capsular rexes the way you prefer to do it. This is how we do a perfect spiral capsular rexes. After staining, you make a nick and then gently move the capsular. After doing a small rexes, take a long handle capsular rexes forceps and then gradually go on extending peripherally, circumferentially and gently moving around. Sorry. Can you play the video, please? Yeah, so as we complete the capsule, this is unedited video. So after completing the rexes, the nucleus is usually free in these cases, so you can just rotate and then manage the nucleus as per the surgeon. We normally do a direct chop, break it into small pieces. After completing the removal of the nucleus. You can put the lens of your choice. This is the next video with a white hard cataract. So after completing the rexes, we usually make an initial groove, then do a direct chop. Usually there is no cortex in these patients, so you can see the frontal globe behind. Crack it into small pieces. You can see the cortex is all stuck to the nucleus. There is no good fundal growth, there is no cortical support. And once you have removed the whole nucleus, you can put the lens of your choice. Here is a 80-year-old patient where you can see a white cataract with a fibrous capsule. It was not possible to do a routine kerexis, so we were trying to puncture it with the cystitome, doing an old can opener technique, trying to cut the bands, even cutting some of the bands with the scissors. We had kept a vitreoretinal surgeon stand by in case there was subluxation or any complications. Gradually and steadily trying to complete the rexes. Once we completed the rexes, we could remove the nucleus. We did MICS here because we did not know how the response will be with the cataract. These cataracts do very well as they have improved from hand movements to 6/18 or better, and these patients are usually very happy. Some of them may have post-op complications or inflammations, and some of the hard cataracts may have post-op corneal folds. Hope for the best and prepare for the worst. Keep your standby tools ready like CTR, pupil expanders, vitreous cutters and 3-piece IOLs. I would like to thank my daughter Samita who helped me to prepare this talk and edit the videos. Thank you all for patient hearing. Thank you.
Wonderful, Dr. Mulani. This is a very nice keynote address.